We'll talk about PCI. Anybody been to the cath lab yet? All of you? You guys want to do interventional cardiology fellowships? Fantastic. Only 2 hands, so the rest are heart failure guys, huh? Well, PCI has evolved a lot, changed a lot. We'll try and summarize it as much as I can. I just want to ask a very quick question to the guys who are coming from internal medicine to cardiology. How often do you think stents fail? Any guess? Less than 10%? 10 to 20%? 20 to 30%? Less than 10%? Good. Well, I'm glad to see that, because 10 years ago it was much higher, and we have changed. We are trying to change that perception, and I think it has pretty much changed. There are indications of doing PCI. This can be a whole conference of 3 days discussion, but I'll just summarize it. Obviously, STEMI and non-STEMI. In non-STEMI especially, we are focusing on early invasive strategy. So the sooner to the cath lab, especially in the first 24 hours, if not even 12 hours, is better. So is for unstable angina. Stable angina, that is a massive debate. It goes to this very basic concept: if PCI reduces mortality, does PCI actually save lives versus medical therapy? And there's an ongoing debate, and because of that, we actually do not routinely rush into PCIs for stable angina. Medical therapy is always treated as a first line of therapy. Angina equivalent, obviously high-risk stress testing is something which you guys are going to come across very often. So patients who are asymptomatic or mildly symptomatic, it's very important that everybody has an evaluation with a stress test and a large defect. In patients who have multivessel disease or complex anatomy, especially if they're diabetics or with low ejection fraction, we strongly recommend a heart team approach. Contraindications, I guess, I don't know any, but no, I'm just kidding. There are some. I had to come up with some, so make it fair and balanced. So related to clinical contraindications, obviously the big one is intolerance or inability to take long-term antiplatelets. I think that's a no-brainer there. Presence of any significant comorbid conditions that severely limit the lifespan of the patient, and obviously chronic kidney disease is one of those related contraindications, and try to optimize medically. And geographic, the list is growing shorter and shorter because of some of the advances, but very small vessels, such as less than 1.5 millimeters in diameter, saphenous vein grafts are just tough. They keep on failing or keep on coming back to the cath lab, so kind of a no-gain, no-end-game strategy there. And certain other coronary anatomy, whether it's severe calcification, tortuosities, and CTOs, this actually is the number one reasons where we look at other revascularization strategy, the ones we don't talk about, called bypass surgery. But that is what we use for difficult anatomy. So let's get to the bottom of this stents. We are in the company of Dr. Reisner, who actually did the first stent. So guys, here we go. So stents are changed. They have changed a lot of advances. We used to use stainless steel. We had gold and all of the, basically any elements and metals you can think of. But today's metal alloys include cobalt chromium and also platinum chromium. There's new designs in the architecture, the delivery, and the drug delivery stent obviously has changed everything else. DES has demonstrated significant reduction in restenosis and TLR. What's the accepted restenosis for second generation DES? 10 to 12%. What is the acceptable TLR on second generation DES, the ones we use today? 6 to 8%. And these are the numbers everybody ought to remember and know. So, and we keep on working on this. So, from bare metals to first generation to DES, second generation DES, we really made a lot of remarkable progress. The current drug molecules we use are everolimus and zotarolimus. We have moved away from paclitaxel for at least in US right now. This is a little summary slide very quickly of 3 or 2 decades of where we are today. So the first generation is labeled on the left in the red color. Cypher, Texas, and Endeavor. We don't really have that available in US. It is available OUS. The second generation is the one which you guys are going to come and get used to. These are the names: Resolute, Promus, and Zions. So what are the differences? Just look at it very carefully. Cobalt nickel is a stent material, the alloy. For the Promus is platinum chromium, and for Zions is cobalt chromium. The strut thicknesses are all below 90 microns. So we have gone away from 140 and 120 microns. They are becoming very thin. The polymer is basically nothing but a plastic layer. We have to put on that metal alloy for the drug molecule to adhere and have a regulated delivery out of that. And the thinner the polymer, the better it is. So we are now in the 4 to 8 micron polymer thickness. The drug, as I said, we have basically found zotarolimus or everolimus, and everolimus probably has the most scientific data. The elution time frame, we have spent a decade finding out what is the correct elution time frame. Do we leave it forever? Do we give it only for the first 7 days? Do we give it for 90 days? Well, it turns out the Goldilocks, the zone is basically turning out to be 60 to 90 days or 60 to 120 days. This is a quick example for guys who haven't been to the cath lab. This is what the right coronary artery looks like. And there's a catheter. We identify the lesion, which is pretty obvious, right, guys? In the distal RCA, 90%. And once we do that, we have a guide and then 1/1000th of an inch wire, which allows us to cross the lesion. We pre-dilate the lesion with a undersized balloon to see how it opens, if it yields or does not yield. Once that has been done, we basically put in a stent, and that's what it looks like. Patient usually, it takes about half an hour, 45 minutes to do that procedure, and person goes on the next day. Our technology is advancing. We actually have another stent which was approved last year called Synergy, and that goes to this new concept of biodegradable polymer. Polymer has been thought of as nothing but an unnecessary plastic. Now, some people feel that it is thromboresistant, maybe it causes fluoropassivation, maybe there's a role in actually improving long-term outcomes, but there's also a large school which says maybe the polymer is best gotten rid of. So Synergy, and there are various other products, but this is one is available in US now, where the polymer degrades at about 4 months and the drug elutes at about 3 months. What is also very unique, apart from the fact that this is one of the thinnest strut, is that now the polymer is only on the abluminal side. Think about this. The restenosis responses does not come from the vessel wall side. It comes from the abluminal side. That's where all the muscle cells are. So it's great. It's very important that we keep the polymer and hence the drug molecule only on the abluminal side. The second, which got approved last month, is called Absorb. Many of the hospitals, very few have it today. By the time you guys in the cath lab in the year 2 and year 3, probably vast majority of your programs will have this available. It is a PLLA backbone, so it's nothing but plastic, so to speak, poly-L-lactic acid. It is semicrystalline in its nature. It's circumferential sinusoidal rings connected by linear links, which is nothing but no really big difference from the multi-link design, which has been very popular over the last few years in a stent called Zions. The challenge here is the strut thickness, which is 150 microns, and they're platinum markers. You can't really see this on the angiography or in the cath lab. You have to use either an OCT or a high-def IVUS to actually look at this, but the platinum markers at the end allows us to implant it across the lesion. The drug is everolimus, and the polymer, it's a PDLLA as a 1-to-1 matrix coating. It is 7 microns in thickness. It is conformal basically all around, and the controlled drug release similar to Zions, cobalt chromium. So as I said, the thickness is a problem here. It is almost more than 70 to 80 micron thicker than current industry standards like Zions, which is sub 90 or 89 microns in thickness, and that creates a massive problem. The early studies, some of the OUS experience, including the recently published Absorb 3 data, has shown that we are actually having slightly higher stent thrombosis, especially when it is implanted in a smaller vessel. Stent thrombosis rates in a current world is accepted at about 0.6% a year. We are seeing about 1.5% stent thrombosis, so almost twice than what we would like to see. So I think this is early days for this technology. Basically what is happening is once you implant this bioabsorbable stent, the drug elutes at 3 months, 90 days. That's all we require for VRT or vascular repetitive therapy. After there is really no need for the drug molecule. Then the mechanical support continues, but it starts degrading in terms of the support physiology at about 8 to 12 months. The mass actually continues and is completely lost at about 20 to 24 months. So this takes about 2 years for the complete resorption of a bioabsorbable stent. I'm only telling you guys this one just because A, we don't have enough time, and B, this is the only one approved in US, the one you're going to see hopefully in your cath labs very soon. There are other devices, yeah, in the PCI world, which mentions a little bit more information. So atherectomy, these devices are designed to physically remove coronary atheroma, calcium, and excess cellular material. There are also two varieties, rotational or orbital atherectomy. The orbital one relies on plaque abrasion and pulverization, and it is used mostly for fibrotic or heavily calcified lesions. Atherectomy devices are really used to facilitate the stent delivery in complex lesions. Laser atherectomy was fairly up and coming when I was a fellow, but no longer the case. Atherectomy is typically almost always followed by balloon dilatation and stenting. In other words, it is not the only procedure you'll ever do in that artery. There are other devices. Dr. Barker mentioned IVUS and FFR, so I'll not go into that, but that is becoming very common play in our cath labs and in the PCI world. Thrombus aspiration, what seems so logical, I mean, if somebody comes in the STEMI, has a thrombus, and you should suck it out, and patient ought to do better if you don't suck it out. Well, in trials after trials, that is actually not shown to be the case. There was a very large trial called the Total trial out of Canada, which showed that routine use of thrombectomy catheter did not lead to better outcomes, whether it's reduction of death, readmissions, or reinfarction, or even stent thrombosis. So routine use of thrombolytic thrombectomy catheter is discouraged, does not mean we should never use it. Distal embolic protection, again, there have been studies in acute MIs, STEMIs, large thrombus burdens, but one area which we see and use it quite often nowadays, and we strongly recommend it, is vein grafts. So it's time and again you guys will come across cath lab reports that we use a filter protection and then did a vein graft stenting because of high debris. What about the antithrombotic treatments? So aspirin obviously is given to every patient. In the cath lab, we use unfractionated heparin. If somebody is just going to be using heparin, we use 100 units per kilogram during the PCI. If somebody is going to get a additional antiplatelets, then we can sometimes do only 70 units. Low molecular weight heparin, but most commonly nowadays becoming very popular is bioabsorbable. We maintain an ACT in the upwards of 250 to 300 for a successful and a thrombotic-free environment. Fondapyrinix is mostly used OUS because there has been some reports of catheter thrombosis. What about antiplatelets? So patients receiving stents are treated with a combination of aspirin and P2Y12 receptor inhibitors, and currently we have 3, clopidogrel, prasugrel, and ticagrelor. There are some differences. Probably the last 2 are more potent, a little bit better platelet inhibition, faster acting, and probably the preferred, except that it costs way more than clopidogrel does. However, the routine use of newer agents have not become common play because trials after trials have shown that it does not really translate to clinical outcomes in terms of overall benefits. The minimum duration of P2Y12 receptor inhibitor therapies, or as we call DAPT, according to the current guidelines, which got revised 2 months ago, bare metal stands for is minimum for 4 weeks. DES is minimum now for 6 months. Remember, there was a time where we were stuck at 12 months, so gladfully we have actually reduced this to 6 months. Remember, these recommendations are patients with stable ischemic heart disease, but anybody with unstable heart disease, ACS, MIs, STEMIs, they all ought to at least receive 12 months based upon other data such as CURE trial. Use of proton pump inhibitors, because this will come up on the cardiology floor services, is appropriate in patients with multiple risk factors for GI bleed who require antiplatelet therapy. So again, there is some interactions with clopidogrel, but not completely contraindicated. What about glycoprotein inhibitor therapy? This was in 2000, probably every conference we went to, we talked about this, such as apixaban, tirofiban, and eptifibatide. By the way, Dr. Reisner would not allow me to graduate unless I could say how to say those names, but they have been shown to reduce complications in patients undergoing coronary stenting. However, evidence supporting their use was largely established before the use of oral P2Y12 inhibitors, so less and less of getting them are used. Several studies have failed to show the benefit of upstream administration of 2B3 inhibitors in the era of DAPT, because 2B3 inhibitors increases the risk of bleeding and their routine use is no longer recommended. It can be used as an adjunctive therapy at the time of PCI, again on individual basis, whether patient has large thrombus burden or there is inadequate platelet inhibition or there is slow flow and things like that. Complications. MI, death, stroke, all can happen. One of the risks of thrombectomy, we talked about thrombectomy, how it is not used is, believe it or not, is actually stroke, and possible reason is because the blood clot actually gets sucked out into the guide and goes out of the coronary into the aorta. Excess site complications, and that's where the debate between radialist and femoralist comes along. Obviously, radial artery interventions have less excess site bleeding. That being said and done, the overall bleeding is no different between radial and femoral sides. Non-excess site bleeding is probably the biggest challenge in our field, whether it's GI or IC. Contrast-induced nephropathy, the best way to prevent it is to use less contrast, stagio procedures, and hydrate. Everything else is not working, whether it's mucomist or whatsoever. But CI, you usually see at 48 to 72 hours, and most of those patients, creatinine will start trending down after that. Allergic reactions, radiation exposure, perforations, and stent thrombosis. Stent thrombosis, I'll leave you guys with this very important slide. It's very important that you all understand what is the ARC definition of stent thrombosis. Every paper you'll read on PCI World will talk about early stent thrombosis. Acute is less than 24 hours, which is usually associated with procedural issues. Subacute is 24 hours or day one, afterwards up to 1 month. So these are called the early stent thrombosis. Late is between 1 month to 1 year, and very late is after 1 year. Where are we going with the PCI world? I mean, you guys are entering a very exciting phase. In the next 3 years, you will see that there is going to be new ways we are going to do PCIs, because from the 1970s when we did POBA, which is plain old balloon angioplasty, a lot of patients required open heart bypass surgery because we will tear and dissect and perforate those arteries. We have moved to bare metal stents, which kept the artery open, but with about 30% restenosis. Now we are in DES, especially the second generation DES. As I said, the ISR rate's about 10 to 12%. However, as we go forward in 2015 and forward, we are looking at optimizing the healing of those stented segments, because we want to do these three things. We want to do, number one, have low stent thrombosis and lower TLR even more. We need to reduce our prolonged DAP duration. OUS, they are looking at 3 months, they are looking at 1 month. I mean, this technology is really moving very fast, and obviously we want to reduce the risk of neoatherosclerosis. We are having new platforms available to us, so thank you all very much.